To start our first session, let's all welcome Miss Mimi Martin.
Good morning to all guests, doctors, patients, and partners. I am Mimi Andaya Martin, and it is my pleasure to be your moderator for this session. We have a packed session today. We will start with wait. There's more post-treatment in breast health. And we have Dr. Dizon, Dr. Margie Holmes, and Dr. Virgilio Novero. What an honor to listen to these practitioners. Let's begin with the session with Dr. Dizon, who's very, very impressive. So he is a medical oncologist specializing in the care of women with breast or gynecological cancer survivorship, particularly as it pertains to sexual health, for men and women with cancer, patient engagement, and social media. He's also a professor of medicine at Brown University, the director of women's cancers at Lifespan Cancer Institute, and director of medical oncology at Rhode Island Hospital. Dr. Virgilio.
All right, thank you very much. And again, congratulations to ICANSERVE for a really wonderful meeting, and then to my friend Carolyn Taylor for her organizational efforts for SEABCS. May I have my slides? All right, so I was asked to talk about follow-up. How do we do surveillance, which is, the monitoring for making sure you're healthy and well, and to make sure that if your cancer comes back, we find it before it's too late. And everybody who gets diagnosed with cancer, breast cancer or anything else, they still say the first thing that they think about is, am I going to die of this? And even after we treat and we say, you're fine, you're going to be fine, it's still something that people do struggle with, wondering if they're going to die, if it's going to come back. And one of the ways that we can help take care of people as clinicians, as doctors, is to say that we are going to follow you. We're going to follow you closely. But what that means is very different. So here's the premise of my talk. Less is probably more. And I'm going to explain that on this conversation, because we have a lot of things we can do. We can do it very frequently to make sure you're okay. It's everything from just an exam where you're coming into the office and you're talking to us and telling us what has happened since I last saw you. We'll do a physical exam. But think of all of the things we can do to image you, from just looking at the breast and the chest wall with mammogram all the way up to breast MRI. We can do a CAT scan of your entire body to make sure that at that point in time, you have no evidence of that cancer. We can do PET CT, we can do bone scans, we can do bone densitometry, and the difference is bone densitometry, do my bones look old? We're looking for osteoporosis. Bone scan, is the cancer in my bones? We're looking for bone metastasis. So it's not the same kind of test. We can even do brain MRIs and CT scans, because some people are very worried their cancer is going to go to their brain. We can do genetic counseling. We can do genomic testing. Genetic counseling, did my mom or my dad's genes pass on to me to give me this cancer? Genomic testing, what's on this tumor that will tell you how better to treat it? This is what Jane and I will discuss for every clinical case. And as you heard, there are many things we can test now. We can even look at your heart if you received doxorubicin to make sure that it's, there's an echo. You guys, there's an echo on the slides. We can even do a lot of lab work. So every time you come in, we can check your blood counts for anemia, make sure you don't have low platelets. We can look at the kidneys and the liver, your magnesium. We can look at alk phos, which might say it's in your bones. okay? We can check your vitamin D, we can check for your estrogen levels. We can do a lot of things. As you sit there and as you listen to this talk, the question that I want you to ask yourself is, what's the purpose of doing these tests? Because there's a lot of things. Breast cancer is not the same. There's 4 major subtypes, right? Everyone's cancer is going to be different because it depends on when you were diagnosed. It also depends, what other problems do you have that you're dealing with today? Okay? Is breast cancer the thing you should worry about most? If you have heart failure and cannot walk to the front step, is breast cancer your most pressing health concern? We also take into account the tumor. What stage were you at the diagnosis? Stage 1A, in which case surgery was probably curative, or stage 3, where you might have reasons to worry it's going to come back. And it depends if you have ongoing treatments, sort of maintenance therapies. In hormone-positive breast cancers, it's the use of anti-estrogen therapies. And the 4th is very important. It's not me telling you how we're going to follow you. What would you like to do? That is paramount in doctor and patient decisions. So one of the first questions that was asked as a community is, who should you follow up with? Your oncologist or your primary care doctor? Okay. After treatment is ended, who is better at the follow-up? Eva Grunfeld out of Canada has asked that question in 2 randomized trials, one going back to 1996. And she compared hospital-based to primary care follow-up. Okay? And what she said is in bold. There was no difference in the detecting of recurrence. The rate of recurrence was the same no matter who followed you. There were less deaths due to breast cancer if you had hospital-based follow-up, but the numbers are very small. And there was a lowered pickup of metastatic disease, but it took the same time to detect that metastatic disease. So maybe your oncologist doesn't need to follow you. She asked this question again in 2006 in early stage breast cancer. Family practice versus specialist follow-up. Again, no one was better than the other in detecting recurrence. No one was better in keeping you alive. There's a similar rate of deaths. And no one helped you feel better in the follow-up. Your quality of life was the same, no matter who followed you. So the second question is, how intensely should you be doing the testing and the blood work? So this is one thing that was published on that. And it looked at people who got bone scans and chest x-rays every 2 years. So no matter if they were symptomatic or not, they did bone scans and chest x-rays. How many people did they detect bone metastasis at that bone scan? 1 in 10. So 1 in 10 people doing bone scans for 2 years were diagnosed with metastatic cancer to the bone. 9 in 10 were doing those tests probably unnecessarily at 2 years. What about chest x-ray? Did we pick up lung metastasis? 1 in 20. We detected lung mets in 1 in 20 people. And in the vast majority of those folks, they didn't have symptoms. So we picked it up early, but to what result? The yield with bone scan and chest x-ray every so often for 2 years is very low. So we're exposing you to a lot of tests with very unlikely benefits. This was a randomized trial in Italy that took people with stage 1 to 3 breast cancer, though. And here you see you had either intensive surveillance, you were getting bone scans, liver ultrasound, echocardiogram, chest x-ray, blood work. Or you were just seeing me and you were talking to me, and I was examining you, and we were doing blood tests as it was necessary. All right? So very busy slide, but essentially if you just scroll down, there's really not that much difference in the detection of recurrences. The difference was, more often than not, with that intensive surveillance, you didn't even know you had those mets. That was the difference. But to what outcome? You didn't survive longer with more intensive testing. You didn't have less pickup of disease to the liver and the lungs and the bone with intensive testing compared to me just talking to you. It was the same. And you survived the same amount of time. PET scans, we know, are very helpful. It's very available. Everybody asks about it. The question is, what can we get out of doing PET scans with regularity? It's very good. If you get a negative PET scan, it's very good that you don't have metastasis. Okay? We have no data at all to say that PET scans help you live. And that's really the bottom line. This is a very busy slide, but it's going to be worthwhile just to talk you through. So this is about, what about testing my blood for cancer cells or cancer DNA? In the blue was how often they tested them all throughout this time. In the blue, the tests were always negative. In the red, it was positive. So at the first row, this is at diagnosis, okay? And you see some people had red, so they were positive, but in follow-up, it was negative. But some people here, and in this black, these are the people who developed breast cancer metastasis. And if you look here, there's more red, so they picked it up, compared to people who stayed blue, okay? So it seemed to predict or predate the development of metastases if we just looked for cancer DNA in your blood. Okay. But the lead time, so I'm going to start making you worry because your blood test says you're going to have cancer. You're going to worry for 4 months before I find it. So I can say it's somewhere based on your blood, but I won't know for 4 months where it is. Okay? Oh, and also this last line, do you see this last line? The lead time from a positive DNA test to definitively saying you have cancer, back 8 months. So you're living with the knowledge it's back, but you don't know where, for 8 months. And the big question is, how will this impact my survival? How do we use this data? That's what we don't know. So instead of intensive focusing, these guys are going to tell you about living well after breast cancer, because we want to encourage activity, we want to encourage exercise, nutrition, we want to help you psychologically deal with the fear of recurring, because that's very real. We want to query you about sex, sexual dysfunction. We want to screen to make sure you're not becoming poor because of your breast cancer. And we want to engage you as a patient in your own care. So again, I'll conclude here. These are the tests we could do, but in my own practice, these are the only tests I order. I don't do a lot of testing, but I see people, I look them in their eyes, and I talk to them. And sometimes they'll tell me they're worried, and sometimes I'll tell them I'm worried by what I am hearing or what I am finding on exam. And that is more important to me than what any CAT scan, PET scan, or blood tests can tell me. So evidence-based breast cancer follow-up is based on personalized factors. Your cancer at its stage, your life, your health problems beyond breast cancer, your preferences. but the evidence tells us that generalists can do this as well as specialists, and that testing is a double-edged sword that can raise anxiety, make the cancer recurrence fear even worse, may be falsely positive, meaning that it's concerning, but after I put you through 10 other tests, you're fine. May be falsely negative, meaning that CAT scan that's negative today doesn't tell me what's going to happen at the end of the year. And it can be very falsely reassuring for that reason. The threshold to incorporate more testing is what we need to figure out together. What will say this is a test worth doing? Is it detecting that recurrence early, or is it doing everything I can so I live a long life? It's not the same thing. Thank you.
Thank you so much, Dr. Don. That was really interesting, no? Parang what I gathered was ignorance is bliss. You know, I mean, if you have all of these tests and it doesn't, you know, just stresses you out for 4 to 8 months, holy cow, we don't need that. Thank you, Dr. Don. And the next one is, we probably know her. She's a hit in our generation. Dr. Margie Holmes. She's a popular psychologist, practicing until now, and a multimedia host in the Philippines. She is a weekly contributor, columnist in the Beleaguered Rappler, and she has published 20 books to date, and is now working on her next book, which is called Triple Whammy, Being Bipolar, Diagnosed with Breast Cancer and Getting Old. Which is a good thing, actually, no? And then she will now. She's also one of the top 5 viewed on the platform, international platform Hook, on her sex talks with Dr. Margie Holmes. So now she's a professor at PLM, and now here she is, Dr. Margie Holmes.
Thank you very much. Okay, let me start with my presentation and cancer, sexuality, and mental health. And I am so glad we have the 2 other experts, ang yabang other, because I'm including myself on sexuality here in case these questions come up, because frankly, I have focused on mental health rather than sexuality. And it's not just because I'm getting older, okay? Anyway, okay, can we have the first slide, please? And this is what we call scanxiety, which you all know. And I just made it a cartoon, not to trivialize our anxieties, but because there's so much that sometimes we need something lighter. And it is wonderful that Doc Dondi and our other speaker, we've talked many times together, you know, share with us the information and the knowledge so that this anxiety goes down more. Don't worry, Doc. Don't worry. Okay lang yan. Okay? Okay. So, next slide, please. I put this up because in terms of mental health, one of the problems, at least that I have encountered, is sometimes people blame themselves, or they say, why me? Which in a way is blaming yourself. You know, why me and not that person? She's so much luckier. What did I do? Or what, etc. And I think this is something that we have to deal with, because if not, we will allow everyone to finger point at us. Chrisanne, can I just share what you told me? Because, you know, with this book, I hope to write, you know, a lot of people in ICANSERVE are helping me, and Chrisanne told me something this morning. And I said, what is the most tactless thing you heard? You know, when people have cancer, and Chrisanne said she was sitting at a table, and then they were talking about someone else who had cancer, and they said, that's karma. That's because of karma. Can you imagine? So, but can you imagine if you are not as strong or as taray as I know Crisan is? If you're not as feisty as Crisan and, others, my God, can you imagine how that will hit you? Oo nga, it's karma because so-and-so didn't get it, so-and-so didn't get it, but I did. So I think this is one of the things we should be aware of, no? I'm sure all of you have heard tactless things. The most tactless, which did not support a myth, was that someone came to me when I said I had cancer. And he said, I could tell already from his face, or maybe from his personality, it wasn't going to be nice. And I already told him, I don't want to hear it. And he said, no. I have 7 friends this year who had cancer, and they all died. Okay? I mean, who does that? Okay? But, I guess what I'm trying to say is all these, what we call in Filipino, patuchadas, the stiletto between the ribs. If you feel uncomfortable, if you think, why did this person say this? Is he trying to tell me something? Believe me, he is or she is. No? But that doesn't mean you have to accept it en toto. You don't have to accept it, because it's very important, for you to know this. Because, as we know, things that affect us emotionally can affect us also physically and mentally. And, I'm just thinking, maybe because I'm a psychologist and therefore shilling for patients, even if it just affects you emotionally, that's a big deal. But there is so much research that shows how one kind of unhealthiness moves on to the other. So let's be aware of that. The other thing is, see what things matter. Of course, when you have cancer also, so many people come to you with their advice. Ay, naku, you should try this doctor. He's the best. If you already have a doctor that you're happy with, all of that is just noise, okay? All the shoulda, coulda, woulda, that's all just noise. And granted, sometimes you maybe could have done something earlier. Maybe. Like me, I think was scared and I convinced myself that my cancer, it wasn't cancer, it was hemorrhoid. So you can probably guess it was anal cancer. So I told myself, well, this happens when you have hemorrhoid. So it took me a long time, because of me, completely my fault, to be diagnosed earlier. So, I could have beat myself over the head and said, you should have gotten tested earlier. And in fact, I did, because I'm bipolar, prone to depression, thus prone to blaming myself. But what I always remembered also in terms of mental health is, I forgot to loy. Sorry. What I always remembered is, if you knew now what you knew then, of course you would have behaved more maturely. But then I was kind of stupid, scared shitless. So I didn't even know I should be scared. Getting cancer was the farthest thing from my mind. Okay, so, learn to forgive yourself. Learn that now it's the buzzword in psychology, self-compassion. And I feel so bad that it's a buzzword because it means a lot. It means a lot, and a lot of studies have shown that it can really help you with your health. And, not now, because I didn't write it in my PowerPoint. I will be very happy to share these studies with you. Okay, so, all right. Then next slide, please. I think this is the most important slide. What I really wanted to say, don't blame yourself, right? What I really wanted to say is, it's not all about you, but in a good way. If your husband stops getting sexually excited by you because you have a breast less, or because what happened, because the radiation makes you walk wonky or whatever, this is not your fault. It's not about you, it's about him. Napakababaw niya na yun ang tinitingnan niya. He's so superficial that this should matter. We'll just say you had a wonderful sex life up until your 70s and 80s. And God, I'm jealous, but okay, all right? You had a wonderful time. But you had cancer, right? And so that was the only thing, and your husband changed. is that really about you? Or about this guy who's so, I don't know, looking into something else that he doesn't value 20, 30 years together and the wonderful sex you had together and immediately stops because you look different, you know? I mean, granted, one has to adjust to the differences, but you can if you're interested, okay? I wanted to tell a story. Poor Mimi, she told me that story, it stuck in my head, and I kept on asking her to get it accurate. So you can just wink at me if I didn't get it accurately. This shows this. There were two doctors, and the woman, the female, got cancer, and her husband was a gynecologist in his 50s or so, right? And he told her after that, look, all the studies I've read and maybe my clinical experience shows that this will not get any better, right? It will not regenerate or whatever. And so in the end, they got a divorce, okay? Of course, we should not immediately blame the husband, which I did initially, being my superficial self and not my supposedly professional self. I blame that son of a bitch. You know, his wife gets cancer just because, you know, and doesn't he know that sex and sexual fulfillment is more than genitalia, blah, 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 blah. But then, of course, Mimi, ever so wise, told me that, you know, it could be a lot of men are afraid of breaking the woman or hurting the woman, which is very true. To which I would say, however, the best thing to do is get information. Get information from experts, because if you already have information from the experts, you already have confirmation from your wife that, no, I would love us to have this kind of intimacy, I miss it. You still don't believe. You are not being thoughtful. You are being patronizing. You are saying you know more than what the doctors, the experts have told you, and you know more, or you think your wife, you know what your wife needs. You know, I mean, just something to think about, because this is really, you know, what really matters. And finally, my last slide, please, is I wanted to talk about the sense of agency, okay? Because many, many studies in psychology have shown that this feeling of a sense of agency, that sense that you can make a difference in your life, you can actually do something, really changes things, right? In the past, psychologists used to call it locus of control, you know, LOCUS, not that eats everything, okay? Locus of control. And when people have an external locus of control, they always think that other things matter. These are people, for example, who don't use seat belts, studies have shown, who still smoke. Their lifestyle choices are not so good because they feel, no matter what I do, it won't make a difference. Whereas people who have an internal locus of control, they believe that they can do things to manage their future, to take care of their future, to make it better and brighter. These are the people who take more pains, have checkups when they need to, but not more. Not more if they don't. And what else? To use your seatbelt, you know, to eat healthily, to not smoke, etc. These are people who have locus of control. So you see there, even in that very superficial level, you can see how that makes a difference in your life. And therefore, this sense of agency, not just who controls you, but yeah, I can do something. I can do X, Y, and Z. This, I think, is what me, I will talk for you, myself as a cancer survivor needs or needed. Okay, because if not, everything is overwhelming, and all you do is refer to, hope to see the doctor, and if the doctor is, you know, really good and, you know, is well known, has a great reputation, it takes, you know, it can take weeks before you get an appointment. So this sense of agency really, really matters, and has been proven, as I say, it's not just pop psychology, has been proven time and again to really make a difference, not only in one's physical health, but in one's mental and emotional health. And what was this? Okay, and then I wanted to say, maybe, can we have the last slide, please? This is the way I hope we all think about life. Huh? Isn't it beautiful? I love it. Huh? I love it. Anyway, it could be we were horny and beautiful then. Now we're just beautiful or whatever, but I love this. At any rate, last slide, please. Oh, that's the end, but is it? I just wanted to say when I'm so happy, Cara, you invited me to this thing, even though you may have changed your mind, but I just wanted to say, I will move para more sincere, even though I walk with a limp. I just wanted to say that here, I am so happy because this is the first lecture where I was invited, not as a psychologist. Nakakahiya naman. Oh, I should have run for politics, wearing pa-green. Green paint pala. Anyway, this is, that I'm so happy that I was invited as someone who has had cancer. And I just changed it a little bit down there. Instead of cancer survivor, I just called myself, this is very superficial, mababaw, but it made me feel good. I just called myself, although it doesn't fit cancer thriver. It's not a thriver or a person who thrives. I'm only sharing this because when I did a talk on sex abuse, what I thought and what might happen in cancer is here in the Philippines, when we have someone who has been sexually abused, 5 years old, she's now 15, we always go back to the sex abuse. How did you feel? It must have been terrible. This must have affected your relationships, etc., etc. It is a little difficult for the person to move on. Now, a lot of studies show that if it is trauma, like certainly sex abuse is a trauma, it is embedded in your psyche and in your body, and a lot of time has to be taken to, to heal and go over this. But you do not necessarily have to constantly be reminded and have to constantly have it tied up. You know, every decision you make, everything that makes you happy, everything that makes you angry, it's not necessarily because you were sexually abused. Anyway, so what I told them is, can we move from survivor, which is like, you're barely clinging on, to maybe thriver. I don't know what the word is, but this is what I wanted to do with my cancer. I mean, I'm just, I think, 2.5 years over. So I know, for me, I feel a survivor. I'm exercising, doing everything. But I hope in time I will be whatever that word is. So I know I had cancer. I am grateful for some of the gifts it's given me. For me personally, how many minutes na lang ba? I want to hang up. Wrap up. Okay. I'm sorry, I did not know. Because I only had 7 slides, I didn't know. Anyway, I thought, I feel I found God, which upsets my husband because he's an atheist. But cancer gives you gifts, no? And it would be nice if we were also thankful for those. Thank you.
Always a hit, no? Yeah. That was really nice, Dr. Holmes. And when we say, it brings to mind when we say that somebody lost to cancer, lost the battle to cancer. It's like, hey, we all die, so we all lose the battle somehow. So I'd like, we live, we thrive, we survive, and then our lives end, cycle. It's just one more thing that we go through. Oh, and the next speaker, I always admire, people who go into internal medicine because they're very smart, especially when they also practice endocrinology. Especially when they're professors in endocrinology. So anyway, so here we go. Dr. Virgilio Novero is the founding president of the Philippine Society for Fertility Preservation. He is currently the head for the Center for Advanced Reproductive Medicine and Infertility at St. Luke's Medical Center in Global City. And he is an associate professor in reproductive endocrinology and infertility at the Department of Obstetrics and Gynecology in the UP College of Medicine. Bravo. So if we just touch him, we might get pregnant. so, Dr. Virgilio, please.
Thank you for the kind introduction. I am very happy to be here and excited to be here as president of the Philippine Society for Fertility Preservation. We love opportunities like this. We need help in spreading the word of helping a particular subset of cancer survivors. And these are those who would require fertility. So fertility preservation is an emerging discipline which seeks to preserve and restore the reproductive future of patients with malignancy or even non-malignant conditions. So it came about because of the parallel histories of two specialties. One is cancer therapy, and the other is reproductive medicine, where I am coming from. In cancer therapy, for 4 decades, they improved cancer treatment so that at a certain point, they already improved cancer survivors. At the same time, with reproductive medicine, we improved assisted reproductive technology and cryotherapy so that we now have more chances to freeze our gametes and tissues for future use. So these two fields married each other and formed oncofertility. So I reminded you a while ago that there are now more cancer survivors more than ever, both young and old. And what would be the repercussion of this? There will be a greater demand for more patients who might require fertility. So, and when you talk of fertility in a cancer survivor, the fertility of a cancer survivor overall decreases by about 40%. And in breast cancer, it's one of the worst. It's down by about 70%. And this happens because of the gonadotoxicity, or the toxicity of the treatments that these patients go through, the chemotherapy, the radiotherapy. So, and it would be dependent on the age of the woman and the doses of the medications that were given to them. So, because of this, when a patient goes through and is diagnosed to have cancer, and they go through treatment and they survive, there will be a lot of things going on when they think about quality of life after they survive cancer. And one of the most crucial things that they talk about, or that they're concerned about, is fertility in 10% of these young cancer patients. So because of this, the big societies all over the world, the big medical societies, the American Society for Clinical Oncology, the American Society for Reproductive Medicine, the European Society equivalents, all of them said, so for every newly diagnosed cancer patient who is interested to have fertility, a future in fertility, they must see a fertility specialist to talk about preserving their fertility before they undergo harmful chemotherapy or radiotherapy. And with that, if following that particular dictum, so before you enter cancer therapy, whether chemotherapy or radiotherapy, you must consider doing fertility preservation methods first. Preserve your future for fertility, and then once you do that, then you can do your cancer treatment as needed. Hopefully, you survive the treatment, and when your doctor tells you that you are fit and ready to try to get pregnant, then you can use these frozen specimen for your desire to be a mother or father. So, just to tell you that among patients with cancer, of course, for fertility, we talk about women who are in their reproductive age. So this accounts for about 10% of all cancer patients. And this is a breast cancer symposium, so 10% of breast cancer patients will probably be indicated for fertility preservation methods. In the 2021 Global Cancer Observatory, they said that there were 86,000 cases of cancer, newly diagnosed cancer in the Philippines. Of them, nearly 31%, or about 27,000, were breast cancer. So can you imagine, out of these 27,000 breast cancer, 10%, or about 2,700, will probably require fertility preservation. And in the institutional data of those doing fertility preservation, indeed, 50% are breast cancer patients. So it is very, very important that we get the message across that newly diagnosed breast cancers, if they're young and they don't have children or they want more children, they must engage themselves in counseling for fertility preservation. We do fertility preservation for both men and women, but we are only focusing on the women. There are established and experimental methods that we do, but let's just talk about on the three most common, which are embryo and egg or oocyte preservation, and also ovarian tissue cryopreservation. What do you do there? So the embryo and the oocyte cryopreservation is sort of part of the IVF treatment, whereby they are given 2 weeks of ovarian stimulation. They form so many follicles. We harvest the eggs. And the eggs, if they are single or they don't have a partner, they're stored immediately. But those who have a partner or husband, they are fertilized first before they're frozen. Now, this is the technique of choice for fertility preservation, but the problem is it takes 2 weeks. And 2 weeks might be a problem with the oncologist because they might think that it would unduly delay chemotherapy or radiotherapy, but that is what we recognize, that fertility treatment is secondary to cancer therapy, so we don't want to get in the way of cancer therapy. There's another issue. For breast cancer, 86% are hormone sensitive, meaning with what we do, we give them medications, it will increase their hormones, their estrogen, it might worsen the cancer. So these two particular things, there are ways on how to try to go around them. Like for instance, we start anytime. It used to be that we wait for the first day of the cycle before we start the stimulation, further delaying the treatment. But we now do random start. And when you also give a particular drug, it's called an aromatase inhibitor, letrozole. When we give it, the estrogen levels don't go up. So we don't worsen the course of the existing cancer. The other technique is called ovarian tissue cryopreservation. So this is done in cases where the oncologist feels that the cancer therapy needs to start right away. We don't have 2 weeks because in the first approach we need 2 weeks. Here we're not given 2 weeks, so we need to do fertility preservation immediately. So you can use ovarian tissue cryopreservation. We harvest ovarian tissues, we freeze them in strips. And then when the time comes that the patient has already survived cancer, we can bring them back. We can put it back inside the woman's body, and she will regain her menses. She might even ovulate, and she might even have her menses. So this particular technology right now has been proven. There are some possible risks, however. Number one, there might be a risk that there is cancer seeding in the ovarian tissue that you stored. And also that because it's essentially a graft, it might not take. So these are issues that we're trying to go around with. And there are now techniques that we can solve, that we can use, so that this is becoming more successful. There are now over 200 successful babies from ovarian tissue cryopreservation, including 3 in children before they even ovulate. So this is just the general schematic diagram of how it's done. So as I said, you harvest the eggs, you freeze them, and then when they're ready, when you're there to restore the fertility, you can bring them back into the woman and hopefully they get pregnant. This is not 100%, but at least it gives them a chance for future fertility. On the other hand, with ovarian tissue cryopreservation, you harvest the ovaries or strips of the ovaries, you freeze them, and when the time comes that she can try to get pregnant, we bring them back into the woman. We try to check if the ovarian tissue has cancer seeding. If it's safe, then we bring it back to the woman. And in 3 months, they will ovulate and have regular menses. So just to show you that there have been tests all over the world that the probability of success comparing egg freezing, embryo freezing, and ovarian tissue cryopreservation and transplantation, the success rates are quite similar. Again, it's in its infancy stage. We hope to improve this the way we've improved IVF, but success rates are quite good, quite decent, about 35 to 50% in some, and this is still going to improve. There are problems though, because we are such a new field, there are barriers to fertility preservation. Among them, us healthcare professionals. Not everybody believes it can be done, or we might be intruding into the oncologist realm. Some oncologists would, and you probably know this, Dr. Dizon, are not aware completely about fertility preservation. So they would even not counsel the patients or withhold information because they think treating the cancer is more important. But until they realize when they survive, the patient will say, I want to get pregnant. How do I get pregnant? Why didn't you offer me there was such a thing as fertility preservation before we did chemotherapy? Patients themselves also think that they might be overwhelmed about the cancer. So they think if you do fertility preservation, it will unduly delay their treatment and worsen their course. And there are financial reasons and their relatives also keeping them from treatment. But there are guidelines that say that counseling will do a lot of good in making these patients understand, to be aware. So it has been shown in guidelines that when you do proper counseling and psychological support, it will improve the patient or the cancer survivor's regret scale and also the satisfaction of life scale if they were told that there was fertility preservation. And we only do it in a multidisciplinary level, meaning it's not the reproductive medicine specialists alone doing the job. It's in consonance or in cooperation with the oncologist, with the paramedical people, with the psychologists. We work as a multidisciplinary team. I think that was my last slide, but my message here is help us spread the word about fertility preservation. It might be your last chance to help to store your fertility for the future. If you don't do it, you're forever potentially sterile. So thank you very much.
Thank you so much, Dr. Virgilio. This is very, very important for us because more and more people, more and more women are diagnosed like younger and younger. Yeah. So it's really, really wonderful. And I'm sure Elon Musk will really appreciate this also. So now we have come to the end and we're taking in questions. So if there are any questions, and if there are none, I would like to start. Yeah, I'll start with Dr. Virgilio. Dr. Virgilio, a friend of mine, had cancer and she was treated, and then she did not preserve her eggs, but then she subsequently got pregnant, and then her had epileptic seizure. Would that be an effect of not, you know, of cancer?
I can't say for sure.
Yeah,
it might be, but we can't say for sure. The studies have not come out. But yes, it is true. The effect of chemotherapy and radiotherapy does not result necessarily in 100% sterility. Some would cause 80 to 100%. Certain drugs would cause only 40 to 60%. Some are minimal. So the doctor has to evaluate first what is the planned therapy, cancer therapy, if the patient would really need fertility preservation. Because if they will not, if their therapy is not so toxic, then probably we don't even need to do fertility preservation.
Yeah, good morning. Well, we would like to know more on the cost. How much would it cost for the fertility doc?
Yes. So it's part of the IVF process. So depending on the age of the woman, here in St. Luke's Global, it might range from 200,000 to probably 280,000 to at least collect the eggs and form the embryos. If it's the other treatment, ovarian tissue cryopreservation, so it will be the cost of the laparoscopy to harvest the ovary, and then to store the ovarian tissue, it's an extra 90,000, I think. So there is a little bit cost for both procedures.
Yeah, my question was related to that too. My question was related to my colleague too. I imagine that those treatments are not available in the public system, or are there?
Yeah, the good news, yes, you're correct. For now, it's not available. Right now, it's only available in the 8 private fertility centers all over the Philippines. But the lucky thing that happened was when we were about to launch the Philippine Society for Fertility Preservation, the National Integrated Cancer Control Act was about to be launched, and they pulled me in. So they got fertility preservation as part of the National Cancer Control Act of 2019, and they said that when the budgets are rolled out, it will be integrated. The focus of the National Cancer Control Act will be given to the National Center, which is the Philippine General Hospital, and then regional hospitals, and all of them will get budget. And part of the survivors' budget will include fertility preservation.
Hi. One question that I have for Dr. Don is I was really amazed by the fact that you don't go the doctor house route, which is like pepper all the the shotgun all of the tests. I also heard or read that people who have themselves examined using only their symptoms based, it's as good as when you have regular tests. Would you agree?
No, I mean, I think that's what the clinical trials have shown us. The difference is really, if you're doing all the testing, it's more likely if your cancer comes back, you're not going to know it because we're finding it on an x-ray and there's no symptoms associated with it. But even if we find it, treat it earlier than we would have symptomatically, you're not going to survive longer with earlier detection.
Fantastic. So because I'm really against testing. Too much testing. That works for me.
If you think one of the biggest drivers of anxiety, scanxiety, you said, is putting you through the testing, and I've been on the other side where I've said the scan is normal and seeing the relief.
Yes.
Only for having that person come back a month later as anxious as they were before the test.
Can I ask a question?
Of course.
Doc, so what would you suggest then if taking tests are not that, how can you be healthier or not be as nervous? Is it possible?
Well, so I tell the people that I've ever treated for breast cancer especially, is that it's more important that you and I see each other every 3 months and we talk. And sometimes the cancer will tell you, you'll be doing your day, and then something will be in the back of your head that says something's not right. And I want to know if that ever happens. Because sometimes you get a sense that something's changed. And that's all I need to say, okay, well, let's look. Beyond that, if someone is going on and feeling well and everything's good, it's really an exam. Make sure you look at the breast and the chest wall, look at the skin, feel for the liver. If all of that is okay, I'm going to say you're fine. And I'm going to say you come back in 3 months.
Kirsan, would you like to say something?
Does it work? Yeah? Does it work?
No.
Hi, I don't have a question, but I just wanted to say thank you for the three of you because 2 decades ago, I wish you were there. I wish I wouldn't have taken a multitude of tests, a barrage of tests every 3 months. I wish mental health was in the picture with a panel of the doctors. And when I was 26 with 1 ovary, nobody thought of preserving my fertility. But luckily, with 1 ovary, I had twins 1 month after. But thank God for all of you. Thank you.
I think we're supposed to wrap up already. No. Okay. Offline, maybe we can have more questions. Okay, so we'll wrap it up, and then I know you have lots of questions with Dr. Margie Holmes. I do. Okay, so thank you so much for coming, and au revoir.